Good afternoon. I'm Doug Devries. I'm from Eye Care Associates of Nevada, and I'd like to welcome everybody to Pardon the Obstruction. And I am joined today, this is going to be a panel discussion about MGD, and I am joined today by two brilliant doctors. We have Dr. Liz Yu, an ophthalmic surgeon from Virginia Eye Consultants in Virginia Beach, Virginia. And Liz, tell us a little bit about your practice.
Thank you, Doug, for having me on Pardon the Obstruction. I feel honored to represent the East Coast on this very important topic. I am a cornea and cataract surgeon in a multi-specialty practice along the Eastern Shore of Virginia. There are 20 plus doctors within our practice, and we cover every subspecialty but pediatrics. With that being said, every subspecialty not only sees but creates dry eye disease. MGD is a huge issue that crosses all subspecialties, and it ultimately, if intractable, falls in our laps as ocular surface disease specialists. So this is so important for us to pardon the obstruction.
Well, great. And it's great to have you, Liz. And also brilliant, but not nearly as pretty, we have Dr. Walt Whitley, and he's from Eye Care Associates in Nevada, formerly from Virginia Eye Consultants. You folks may not know this, but we have a couple of really important events coming up. And today, March 4th, is one of those events, and it's National Grammar Day. And then in just a couple of weeks, what we have is St. Patrick's Day. And so, Walt, with that, what I'd like you to do in a couple of grammatically correct sentences, can you tell me why your Irish lineage is so important to you?
Well, I was ready for this day, and I'm going to say, dude, I'm Walt Whitley, and dude, I'm excited to participate in this PTO. Hey, I'm Irish. I look it, I feel it, I act it. So that's why I'm so excited about the day. You know what I'm even more excited about? It's not a day, it's a month. And so we're going to celebrate St. Patrick's month this month, and we're going to start right now. And as for grammar, I did look at the, one of my favorite words is dude. And so I look at the etymology of it as well, and it's used in so many different ways. Actually, dude came from the song Yankee Doodle, but they made it shorter. But there's so many different ways we can do it. It's to be a noun. Like I know Liz loves the word dude, and she's excited. She goes, dude, or if there's something going on, I'll say dude, or just how we approach people. And so, but thank you for bringing up both of those days for me. I really enjoy them both.
Oh, absolutely. And, again, you failed the grammar. Liz, I'm not buying it. I'm not buying this whole Irish thing whatsoever. I think it's fake news. I think he plays this whole rosacea thing, an Irish thing, for the pardon the obstruction. And I think he's just trying to get free IPL so he can look prettier.
I'm thinking you might be right, because Walt is just being a narcissist. You know what I mean? I mean, it's all about Walt. Between the three of us, who looks the most Irish? Me. I mean, come on.
And once again, I missed that one. But in Walt's honor, cheers, my little Irish buddy.
Cheers, buddy.
Cheers,
Liz, we forgot to get you one.
And Walt, I'm going to turn it over to you now, since you kind of failed this whole grammar and this whole Irish thing. So I'll turn it over to you so we can talk about Pardon the Obstruction.
Well, welcome everybody, and welcome to Pardon the Obstruction. We do want to give a shout out to PTI. If you haven't seen why we were just doing what we did, you may want to take a look and Google PTI and see some of those episodes. But essentially what we want to do is we want to talk about MGD and looking at the obstruction and how it impacts our practice. And so the overview for today is we're going to look at various MGD topics in a fast-paced environment. We're going to have a timer, and so I'll cut you both off, or we'll just switch topics right away. But it's going to be rapid fire. We're going to go into these, so let's go ahead and get started. So why MGD? We see this day in and day out within our practice. I mean, we all have patients that suffer from this. Liz, why MGD and why does it matter?
So I'm just going to start with one statistic, and it's that might be the only statistic that I actually know, but I know this one to be true. Moken and others demonstrated that 96% of prostaglandin analog users have meibomian gland disease. It just shows you, and that's first line therapy for all glaucoma patients beyond SLT. So that alone, and that's just representing like what it is, because again, over 80% of dry eye disease, imbalance of the tear film, involves some level of MGD. MGD then creates this vicious cycle that causes all sorts of havoc, but it can affect our daily lives, our outcomes. And it scares me that all our kids are on laptops, digital devices. We have 20-year-olds coming in for a LASIK evaluation and 50% of their glands have already dropped out. What is going to happen to us? So this is why I care about the obstruction.
Doug, what do you think?
Yeah, I agree. And I think, not only glaucoma, and that's a stunning statistic that we have on what happens with the prostaglandin analog. But equally as stunning is the study that Priya Gupta did on her pediatric patient between age 4 and 17 and found 42% incidence of clinical significant meibomian gland dropout. And like you mentioned earlier, Liz, you're talking about light emitting devices and how often, how long kids are on it from age 2 forward. But when we start seeing clinically significant dropout that there shouldn't be, yeah, we really do care about the obstruction.
Yeah, and so when it comes to MGD, it matters because it affects every one of our patients. It affects all of our practices, and it's something that does help lead to our optimal patient outcomes. And this is something that we have to be looking for. It's not, and we have to ask the questions, but we also have to look, express, and address these for our patients. Moving on, we're going to go into risk factors. And so you both just started talking about some of the risk factors. One of the studies you just mentioned, Liz, was in regards to the prostaglandins. We know Rita did a study as well that had a very similar number where it was very high prevalence of MGD. Doug, what are some of the other risk factors that you feel affects MGD?
Living.
Well, that's a great one.
That's the number one in my practice. I mean, until proven differently, patients have to prove that they don't have MGD because of the prevalence and the way we see this ramp up. So certainly time, and I think it's a question now we all ask as practitioners, and that is, how much time do you spend on a light emitting device? How much of your day is made up of, whether it's doctors being on electronic health records, whether it's reservation agents, everybody is dealing with this digital world. And when they're not dealing from an occupational standpoint, they're dealing from a social media standpoint and finding, all of their information, doing all their shopping. So I really think that we have, such prevalence out there now that they have to prove it. So really looking and delving into those other risk factors. And of course, those patients that answer positively on a questionnaire. I mean, those are another group that we have to take a look at. But until proven otherwise, they have MGD, and it's a potential problem.
Liz, what about for your
I'm gonna throw this out there. You are absolutely right. Upright bipeds now have multiple risk factors as to why we develop MGD. Now, certainly it can be due to an inflammatory or maybe an obstructive process like rosacea that's leading to inflammation that is affecting and spilling onto the lid margin and affecting all of the oily glands. But it may be due to a primary source like Demodex, which may itself, with its exoskeleton and its digestive factors, lead to more congestion. But truly, MGD is at the root cause of everything when we're not blinking and having a full blink to express the meibum. Then the meibum builds up and creates this pressure atrophy and thus then destroys architecture. So once we see architectural dropout, that's already a next level of meibomian gland disease. Having full glands and bad meibum is the biggest risk factor right before you're going to start seeing dropout. And that's why it's so important that we are looking to express and take care of these patients. But when we're in contacts, when we're staring at these light emitting devices, going from an iPad to the iPhone, to the watch, to the computer, back again using multiple, starting at 6 a.m. to 9 p.m., how many times are we blinking? Not the normal 8 to 10 times per minute. We're blinking maybe once every 30 seconds. That's
Well, I'm
not
blinking a
enough.
lot right now, Liz, so I'm just listening to you.
And Liz, I don't know if you're suffering from this right now, but are you having a difficult time looking at our little leprechaun buddy?
So anyways, Doug, you just mentioned earlier about Priya Gupta's study, and listening to you as well, Liz, when we look at that age, those were younger patients, and about 42% had grade 1 MIBO score. And so they already had atrophy. They already had some tortuosity as well. And so, we're talking about risk factors, but, if some people start like that, a young kid, I mean, what are their risk factors? And so there's so much to be learned about MGD, but we have to keep moving on. And so, dude, we're going to go to evaluation. And so whenever we're looking at our patients, we always have to have a protocol in place within our practice, where it starts from the front office to what our technicians do and what we do as well. Liz, tell us about your evaluation. What's most important to you when you're identifying patients with the obstruction?
Yep. So this is to be true, Leprechaun Walt, that my evaluation for either LASIK or cataract surgery always has infrared meibography, because how much I believe that is probably one of the most important tools for me in my toolbox for looking at the overall ocular surface and seeing. It gives you a cut and a point picture, like a snapshot in time of where they're maybe at along their process of OSD or dry eye disease, especially new patients that we don't know much about. So that's a huge part of it. But that lid margin evaluation, I have them look down for collarettes, then I have them look up so that I could observe telangiectasis. I look for pitting, meibum quality, and how hard it is to compress and get that meibum to release.
Hey, Liz, can you talk about, so you do that for your surgical patients. So how do you determine whether or not you need to address the glands before surgery? Because let's say refractive surgery, they wanted it yesterday. So how do you address that?
If their meibum is, turbid or worse, but they've got good architecture, that'll lead me down the path of at least let's open up the pores with getting something done, like addressing it with microblepharoexfoliation to allow better egress, without having to work so hard, and getting them on oral omegas. And my preference is hydride, because I can definitely see in personal experience, as well as I believe that peer-reviewed literature, that it does help to improve the meibum. Now, if they also are accompanied with dropout, it depends on how much dropout there is as to whether I'll pick LipiFlow versus iLux. And I'd love to get Doug's thoughts here too on that, as where IPL fits into all this, but it actually affects what kind of lens choice I'll pick for my patients too.
Doug,
And
what about your examination?
well, actually, my examination starts at the door. And when I look into that exam room and I see a typical Irish complexion like yours, Walt, then I'm going to suspect that there's rosacea. I'm going to suspect that we could have an increased prevalence of Demodex. I'm just going to take a look. So when we first, before I ever approach the slit lamp, that's where mine starts. But I think, Liz, what you mentioned were so important, and that's looking at structure and looking at function. Because structure will tell us, okay, do they have potential to then have good function, but without looking at the actual function, without pressing on those meibomian glands, because you mentioned, well, if it's turbid, if it's thickened, then that they're going to take a little bit more work. But that's what we have to do, is we take a look. That whole term of obvious versus non-obvious MGD goes out the window as soon as you press on it, because anything that's non-obvious is going to be very, very obvious that there's a problem and that this isn't good meibum. And you can really be fooled by structure too. You look at this structure and you say, wow, it's a full complex structure. And then you press and you realize yeah, this patient is headed down a road that's going to really be problematic. That is maybe on some of them, they are obstructed. They're looking at dropout. They just haven't had it. The segmentation hasn't occurred yet. But I think I agree. The infrared meibography is so critical. And it's something that I feel makes my job so much easier. And that's describing that to a patient. And I always thought I did a pretty good job of describing it to a patient until I actually had meibography all those years ago. And I realized I wasn't doing such a good job, that the picture is worth 1,000 words.
Well, not just a picture. I mean, soon there's ways we can do videos and just show them on what's coming out of those meibomian glands. And I'm sure all three of us have plenty of videos that can demonstrate that. You know, one of the things that comes to mind for me is not just those new patients, but I make sure all of my patients have at least had a baseline meibography, because oftentimes, I mean, Liz, you just mentioned the glaucoma patient. I mean, with such a high prevalence, every one of our glaucoma patients needs at least one baseline test, whether they have diabetes, whether they're for a refractive check, whatever it may be. It's always important for us to set the baseline for our patients and address that accordingly for our patients as well. Anything else you all like to add in regards to the examination?
Yeah, I think we sometimes overlook the glaucoma patient.
Mhm.
And that's because, I mean, we're so concerned about their pressures and their optic nerve and their compliance that sometimes we overlook that some of the non-compliance could be very well because of that dryness, because of that MGD, where they don't want to put the drops in. They just don't feel good. So I think there's, it's kind of a double-edged sword that we look at with those glaucoma patients. Yeah, we're really taking a look to make sure that that patient isn't continuing to lose visual field and sometimes not paying the attention that we need to what's happening with it. Why is that they don't want to be compliant with their drops?
Well, moving on, we're going to switch to the next topic here. We're going to talk about the first line treatment. And there's so many different options that we have for our patients. And when we're talking MGD, we're talking about MGD, dry eye disease. We're looking at that ocular surface. So Doug, tell us about your first line treatment. Is it over-the-counter therapies? Are there different medications I can prescribe? What is your first line treatment?
Well, since with the first line treatment, I mean, if it's a patient that's a new diagnosis and that they probably have the comorbidity of the dry eye anyway. So I'm going to take care of the acute nature of that inflammation that they have. I'm going to then explain to them, we're going to have to do something about these lids, because this is what's happened as a result of that inflammation. Is we've had this obstruction, we've had this atrophy, we're losing this, the quality of the meibum isn't good. But I'll typically start somebody out on a supplement. Lynch, you mentioned Hydride, absolutely my favorite. I mean, the tolerance is really good. And the efficacy is really good as well. So I've been using that with a lot of success for patients so I'll start them on a supplement, but I'll typically also start them on some type of an immunosuppressive that I'll have to lower that inflammation. Now, my goal is going to be to titrate those patients off some of this treatment, as we improve. But I initially explained we're going to take care of the acute nature. We're then going to look at how do we fix the damage that's already been done. And one of those is microblepharal exfoliation, which I do before any of the thermal pulsation procedures. So I could look at that, but I'm going to tell them there's going to be something. We're going to need to look at a LipiFlow, an iLux, a tear care. We're going to need to look at doing some type of thermal expression. And with that, so it may not be the very first thing I do, but it's followed shortly after I initially take care of the initial inflammation.
Hey, so Doug, we hear all this about ethyl ester and TG form. I mean, what are your thoughts? Or Liz, you can chime in on this as well. What is that? Where does that come in? And what are your thoughts?
What was my thoughts on
the ethyl ester versus the TG form when it comes to the omegas and the fish oils?
Oh, yeah. Oh, the ethyl ester versus the TG form. What I found is, first of all, you got to have something, in my opinion, that a patient just can't go out and think they're substituting, because inevitably they will. So on the triglyceride form versus ethyl ester, I prefer, if I was doing strictly an omega-3, the triglyceride form would go to, but they often substitute. They'll go into the big box stores and they'll pick up something that they think they can take once a day, and it's only going to cost them $8 a year for, and it's not doing anything. So that's why I've really gravitated toward an omega-6, omega-3, something like gamma linolenic acid that they can't just substitute. And I think that's more important, at least in my practice, is I want them on what I want them on. I don't want them on just either an omega-3 alone, whether it's ethyl ester or triglyceride.
Mhm. Liz?
And I agree with you, but I will, whatever they're on, I'll make sure to keep them on it. I don't take them off of it. I will, if they're on fish oil, and I will say, okay, well, I know, for example, Nordic Naturals, Carlson's, because I don't have access to PRN. Those are more pure triglyceride forms, and the bioavailability and efficacy may be better in that realm, but I still want for you to be at baseline. All of my dry eye patients, I think a great foundational supplement is going to be getting on an oral omega, particularly, what my super omega of choice is, as I already mentioned it. I do think that some patients need to be quieted down, especially if there is a lot of that telangiectasis and inflammation with vessels there, and they may need an antibiotic and steroid drop or an ointment as we calm it down and then incorporate microblepharoexfoliation. Oral tetracyclines can be helpful. And for those really recalcitrant or really severe diseases, even oral azithromycin, doing it for 3 days in a row, once a week for 6 to 8 weeks, can be very, very helpful to kind of start to jumpstart and get these patients under control. But those blinking exercises, kind of telling them about like a lid kegel or whatnot, but it's that posterior lid, and doing that, that's going to be important to take that break during the day, and eating a diet that's really kind of rich in omega-3s. And you can tell someone who eats a less preserved diet by checking their meibom. And it's so surprising, those whose diets are varied and rich in like, let's say, fish and nuts and olive oil, their oil glands are just better. They just have a better expressibility to it. So diet is definitely another key part to this, but our daily lives does not necessarily lend itself to being excellent at each of these.
That's a great point. And age becomes a risk factor, but sometimes I think age in younger individuals is a risk factor because the nutrition often is very, very poor. And it's a pro-inflammatory diet. So I think that really is, another risk factor.
Yeah. And just to finish off this topic, so we focus a lot on the nutraceuticals, but working with Liz and Doug over the years, we all agree that we need some type of lid hygiene. We have to keep those lids clear. We have to make sure we're addressing any Demodex or bacteria the patient has, the heat, making sure we're prescribing a heat mask for our patients. The nutraceutical as well. But then if you're going to use an artificial tear, typically they've already tried it. We're already going to go to a prescription pharmaceutical, but make sure we're deliberately prescribing what we feel is best for our patients.
Yeah,
now we're going to move on to dude. What's that?
I don't think you can ignore the lid hygiene. It's so important. And I'm so excited for sometime next year with the possibility of Tarsus having approval to really take care of this Demodex and have a definitive, and I tell my patients, hey, if it was just a year from now, I'd really have a good solution. But instead I have a solution where we're going to try and just control the prevalent, or control that the explosion of this. But yeah, I think that what we're seeing in technology, but I don't think you could ignore the typical lid hygiene that you should be doing with the OcuSoft products, with having regular cleansing of that. And then the microblepharoexfoliation just takes it to a whole new level.
Yeah. And don't forget the blinking. That's what Liz mentioned earlier.
I know.
Well, now we're going to talk about the in-office procedures. And this is such an exciting space, and we know that's only going to keep growing and growing. And, just 10 years ago, we only had one treatment, which was thermal pulsation, but now we have other treatments to our disposal. So Liz, what are some of the trends you're seeing when it comes to in-office procedures in regards to MGD?
Yo, dude, I'm not really sure what the best actual treatment is in office, because LipiFlow is great. And all the different generations of thermal products that have come out are non-inferior in comparison as well. I'll say I like the automation of being able to put the actual actuators in and then leave the treatment on for the 10 to 14 minutes. And during that process, it goes through, heats it, and expresses, versus iLux, which I love when I can identify areas and pockets of dropout, because I will target and spend more time there, since I know that at least those areas with glands are expressible versus spending time in areas where there are completely missing glands. I don't have as much experience with tear care, but I know that patients find it to be very comfortable. And we've incorporated IPL, and I've seen some great success from a symptom standpoint with patients. How about you, Doug?
Yeah, when we take a look at the technology, and I think the most important thing about technology is 10 years ago, there was one and one only, and that was the vectored thermal pulsation by LipiFlow. And it was cost prohibitive to a lot of practices, so there wasn't a lot of utilization. Now the cost of that has come down so that it's very, very affordable. And now we have the entry of, you mentioned, iLux as well as tear care. I mean, honestly, there's no reason a practice should not have the technology today. I mean, there's the different entry levels, there's the different ability to do where you can have your technicians do it, you can do it yourself. I think there's a lot of options for the thermal pulsation now. So I really don't see that there's a reason for practices not to have it, and should be addressing it with the prevalence that we have. Now, when we start combining something like intense pulse light and thermal expression. So when I initially started with intense pulse light, I thought it was going to cannibalize some of the thermal pulsation. And what I found out, it doubled it. It just absolutely doubled it, because patients understood the idea of causing a retraction of that inflammation on the eyelids with the telangiectasias, and then removing the obstruction of the from the MGD. So patients really seem to understand that, and all of a sudden they were willing to spend twice the amount of money to get that, and the results really go hand in hand too. So the vast majority of patients, if they have telangiectasias, in my practice, they're actually getting both, and I think in Walt's practice too. They're
Which practice? When I was with Liz or with you? Which practice?
The one where you're at now. And so if they have telangiectasias, we're doing a series of 4 intense pulse light treatments using the ophthalmic settings and a mix of the derm settings, and then finishing with the thermal expression, and getting tremendous results with that. But I was amazed that patients were willing to do both the IPL and the thermal expression, that they didn't choose one or the other. Now, if they don't have any type of ocular rosacea, then we'll just go ahead and do thermal expression on them. But doing the whole series.
Are you doing expression after each treatment for IPL?
No, I'm just doing it at the end of the fourth treatment.
Some people do it every time and other people don't. Liz, do you?
No.
No.
And they come in once every 4 weeks for 2 to 4 treatments, depending on the level of, how much rosacea is on their cheeks and crossing their lid margins.
Yep. We're looking at trends, and one of the things we're hearing a lot about is radio frequency. Liz, what are your thoughts on radio frequency when it comes to MGD? Is there a role, or what are your thoughts?
Only the future will tell us what that role is going to look like. I think only time and experience. I don't have much experience with either probing or radio frequency therapy. So I certainly think that they are there's potential for synergy, just like I believe MBE or microblepharoid exfoliation should be baseline, first line therapy and a great in-office therapy, but that is greatly synergistic with any thermal therapy. And similarly, IPL, if there's vessels, I think, again, add synergy. So I believe there is certainly a role, and that utilizing and combining different therapies can help different facets of MGD management.
Yeah, I spoke with some of our good friends, Tracy Dahl and Selena McGee, because they both have the radio frequency and the IPL. And so oftentimes, as Doug, you mentioned the telangiectasia, that helps them differentiate on which treatment that they should utilize. But, you know, in the end, when it comes to the various treatments, and you all spoke to all the different treatments and procedures that are available, the main thing is to do something. And so, you know, talk to your friends, learn more from Eyes on Dry Eye 2022, and, you know, go to the exhibit hall and hear about what the results are, what the data says, and how it's going to impact your patients, but then how it's going to impact your practice. And so we're going to talk about pearls now. And that's one of the things everyone wants a takeaway of things that work best within the practice. Doug, tell us, what are some of your practice pearls when it comes to MGD?
Well, first of all, I want to take away your hat. Okay. That's the first takeaway. You know, and Walt, I think you said it, you'd have to do something. You have to, I mean, it's so easy to identify that I think that's the first step. I mean, even the speed questionnaire, having that, patients will self-identify with the speed questionnaire and then look at the function, press on those meibomian glands. If I could encourage every doctor in the country and everybody would do one thing, that's what I would say is press on the meibomian glands. That's my takeaway. You can put your hat back on. It was actually kind of cute.
No, too late. There's
a bromance here brewing, and I just absolutely love it. Look at the Irishman turn, the real Irishman turn red in the face as I talk about the bromance. But pearls, I definitely think that showing them the image, and as Doug mentioned earlier, what is that? A photograph is a picture is worth more than 1,000 words, but it truly is. When you show them what normal to severe dropout looks like on the MIBA scale and compare it to their image, that is extremely helpful in kind of carving out the story and then creating a personalized treatment option for that patient. It allows the patients to understand why we are pausing and not moving forth with surgery until I can see how they respond to therapy. I want to know that, one, I can get better measurements, that I can get their evaporative dry eye under better control, that I am going to manage risk factors so that they don't potentially run into really progressive and chronic worsening of their MGD and dry eye after any surgical procedure, whether it be that it's their laser vision correction or their cataract surgery. And then lastly, again, it helps me with deciding, you know, are you okay with doing these kind of therapies and being aggressive about maintenance therapies? Because this is where we're at for the type of dry eye that you have, and you may need to keep it up to maintain your best vision. But if you're not okay with it, I'm not going to use this multifocal lens, which is extremely sensitive to dry eye disease, particularly your type. So, you know, it's a little bit of give and take and customizing it and understanding what the patient is willing to do now and in the future, because, you know, I don't want them to walk away thinking one and done, if that makes sense.
Absolutely.
And, you know, for me, the takeaway is going to be implementing a dry eye champion within your practice, because that's going to be a huge impact or aspect of our practice, because our dry eye counselor, I mean, we have Alexia, the dry eye diva at Virginia Eye Consultants. We have dry eye Louie here at Eye Care Associates, but essentially they're an extension of our message. And so whenever we're showing them their meibography or whatever that we're showing them, they're going to take that and tell that patient, hey, this is why Dr. Yu is recommending this. This is why Dr. Devries is prescribing this. We're just making the strong recommendation, whether it's going to be for tear care, whether it's going to be for LipiFlow, whether it's for the iLux or the soon-to-be iLux next generation. But once we get them to the counselor is going to help get those patients to get the treatment that they need. And I know at Virginia Eye with Alexia, she's awesome. I mean, if you get that patient and start the discussion, get to Alexia, that patient, 90% of patients are going to get a treatment. If not now, eventually they're going to get it. And the same is going to go with dry eye Louie here in Reno, Nevada. And so we're going to move on to the big finish. And so I only need 30 seconds responses from each of you, and we're going to do rapid fire. And so we're going to go ahead and take it away right now. So the first thing, heat versus cold. I was in a discussion at one of the conferences, and we're looking at patients with MGD, and ocular rosacea came up. Liz, do you do hot compress or do you cold compress or no compress? Thoughts on that?
In rosacea, I'd say heat for half the time that you do cold, but finish with cold.
Doug?
Heat. Go with heat. I mean, we still have that obstruction. So I go with the heat, and there's nothing wrong with a little redness on the face.
That's right. And I do the same, Doug. I go with heat. Although if it's a trigger, we know within dermatology that the heat can be a trigger to rosacea. So if it becomes a problem, then we will stop that heat from the patient and then move to a cold compress. Next topic is going to be anti-inflammatories. Patient comes in, do we prescribe, or what is the role of the anti-inflammatories in regards to MGD? Do we need both, or can the patient go without? Doug?
We need both. We need to do the anti-inflammatory, particularly if you've tested the MMP9s with an inflammatory. Yeah, let's lower that. And it may not be long term, but I mean it could very well be. But yeah, that's the starting point.
Liz?
Totally agree. And especially if they do look inflamed, if their lid margins are red, if they're complaining of burning, we need to quiet it down. If we're going to do MBE, especially after that, I'll do a little bit of an anti-inflammatory antibiotic combination ointment. But if it is that they are actively inflamed, we know pulsed therapies of it, just short-term therapies can help that. And the term is flare, but I believe that all of us, especially with MGD, have flares with greater levels of redness and burning.
Mm-hmm. Well, we all have that patient that does suffer from nocturnal lagophthalmos. And so we could put drops on the eyes all day long. We could do the various treatments. How are you all addressing it within your practice? Liz, I'll let you go first.
Ooh, that one's a tough one. Tape, either a mask or something where that is vaulted, and added humidity. Those are my go-to. I hate ointments because patients dislike them, but that's kind of, tertiary level too, adding that on there.
Mm-hmm. Doug?
Exposure is one of the most important underlying causes that you can identify. And I agree, no ointments, no gels. Patients don't like that. Look for the lid misalignment, look for the nocturnal lagophthalmos, and then use Sleep Tight, Sleep Right on that. That is a product that will keep that hypoallergenic, latex-free, and permeable so that the tissue can breathe. And for the first time, we've had a really good solution to actually keep those eyes closed all night long. We can do it unilateral, you can do it bilateral. That's my answer.
I think the big thing is to identify it once again, because we could be doing all the treatment all day long, but if we're not addressing it, these patients are still going to suffer no matter what therapy that we're offering for our patients. And so last but not least, future treatment options. We know the pipeline when it comes to MGD is very exciting. You both take one and I'll take another. So go for it, Liz.
I'm going to pick TP03 and tarsus. Demodex blepharitis, of course, is going to manage the anterior lid margin, but I'm very excited about the potential that it will have on helping with MGD management, especially to clear that obstruction. We know that DB patients have actually bad tear breakup times, which demonstrates that there is definitely an association that exists. It's not like the Demodex is only going to invade one form of oil glands. It's going to go in the lash follicle and the posterior lid margin, with the brevis being the smaller one that likes to hide in those meibomian glands. So that's what I'm looking forward to.
Doug?
I'm looking forward to iLux 2. I think that what that's going to do is going to give some video capability, so you can show the patients. It's going to give meibography. It's going to give portability and affordability. So I think just adding that, I mean, the iLux already is great. The tear care is something that's very affordable, and the LipiFlow. But I think looking forward in the technology, the iLux 2 is going to offer a lot to practices who haven't adopted technology at this point.
Yeah, for me, I'm looking forward to Novo 3. So we may potentially have a drop that's going to be indicated for patients that have the dry eye disease that is associated with MGD. And so in the clinical studies, they just finished their phase 3 studies, both the what's it called, the OBI and the Mojave phase 3 studies, and it did improve statistically significant for the total corneal staining, but also for the symptoms for our patients. And so those are just 3. There's many more in the pipeline, and we can go into looking at the keratolytics. I mean, that's something else we can talk to. But hey, thank you both. I mean, this has just been such a fun and exciting conversation that we had. Thank you for making fun of me for the last 45 minutes here, but I took it all in good fun. And thank you all for listening to PTO, Pardon the Obstruction. We look forward to the rest of Eyes on Dry Eye 2022, and we'll see you soon. Thank you.
Wow. What a session to start Eyes on Dry Eye 2022. Liz, Walt, that had to be a lot of fun.
Yeah, it was a blast. It was a blast.
Anytime I get to spend time with Walt and Doug is a good time.
And I say ditto.
And you look great in green, Walt. I mean, I never knew that about your Irish lineage. That's very, very impressive.
Well, I did bring a backup shirt here. Oh, wait.
Because I'm 1/3 Irish.
But anyway, that's another discussion.
He flaunts this whole Irish thing. He flaunts it a lot.
Oh, Doug, nice to hear you. That was awesome. Good job with that session. Looking at treatment trends in MGD, and what we talked about with parting the obstruction. And maybe I'll throw it to Liz first. The question is, do you feel like there's more of a trend to treating in office right away, or do you feel like in most cases you want somebody to fail conservative therapy before you offer in-office treatment for their MGD?
Oh, that's such a great question. I think that for myself, the in-office trend and doing that earlier is definitely where I lean towards, because I am treating younger patients. And as we know, compliance is difficult across all generations, simply because, we all either are very busy as we are younger, or it becomes a dexterity and obviously maybe even a cognition issue as we get older. So between those two spectrum, just to take that away and be able to do something that I know can logically and scientifically demonstrate to have that longevity of efficacy is really great to see. Thus, I do prefer to start in office, even if I'm just doing IPL and BlephX, and maybe depending on the level of architectural damage or non-damage, I will potentially add a thermal therapy to it, and they always get to take home an oral omega.
Great, thanks for that. On the West Coast, Doug and Walt, what's your approach in terms of initial presentation? Somebody has mild to moderate dry eye MGD, and you are thinking about what is the first step, and is it going to be in terms of managing the MGD and the obstruction part? Is it going to be doing things at home and then coming back to the office for potential in-office therapy, or do you flip the script on that?
Yeah, so typically what I do on something like this is we've already diagnosed the patient. So I'm going to give them things that they should do at home with the nutraceutical, cleaning off the lids, going to prescribe an anti-inflammatory and something to heat the glands. I'm also going to give them information because we've already done the imaging of the meibomian gland. So we already know what their structure is. I've looked at their function. I'm preparing them for next time they come in, they're going to need an in-office procedure. I'm going to prescribe an anti-inflammatory to address the inflammation. And so I'm just setting the stage for that treatment. Typically, we got to remember that compliance is always an issue for our patients. So no matter what we prescribe, they're going to do it not as often as we like them to. And that's why their results from at-home therapy isn't always best. And so doing those in-office procedures, we know the data speaks for itself. And so if they have the issue, we treat the issue.
And I agree. We go ahead and I go ahead and start them on an anti-inflammatory, but quite often before they even come back for their next visit, they're already scheduled for a thermal pulsation. So I agree with Liz and Walt. We try to move to that a lot sooner now, and that's what I'm finding the trend.
Can you hear him?
Yeah, we can hear him. So looking at next question here is, we had over 1,000 people on this session. That is fantastic for Friday afternoon, and we're getting greetings from Costa Rica, all over the place. So this has been just awesome what we're able to do here. Looking at treatment trends in terms of intense pulse light, that's been a hot topic for the last couple of years. And we'll start with Doug on this one. Doug, how does intense pulse light fit into your treatment algorithm? Is the trend to do that more often? Do you do that in conjunction with the thermal? You talked about using blood flow exfoliation as well, but do you find that yourself reaching for IPL more often, or is it about the same as it's been the last few years?
Yeah, no, actually, I found that I use them in conjunction. I mean, the whole theory is remove the inflammation and help do that with IPL, and then follow up by removing the obstruction and do that with thermal pulsation. So if anybody has ocular telangiectasias, I go ahead and I move to doing the combination therapy, doing first the IPL 4 sessions and then moving directly from that onto the thermal pulsation. So use it combined. And patients understand it, and it actually more than doubled the thermal pulsation that I was doing, because I think they do understand it.
So when you're doing those sessions and then you do the thermal pulsation and you see the patient back in a couple months and they're doing pretty well, what's the typical cadence for a mild to moderate patient in terms of timing and when you may do additional in-office therapy?
Typically, I will see those patients for 2 more sessions of IPL, anywhere from 5 to 7 months.
So you'll do 4 sessions, micro blood flow exfoliation, thermal pulsation. At that 5 to 7 months, you'll do another 2 sessions, spaced out by how long?
Yeah, do the assessment and then make a determination. But typically, because patients are getting both the cosmetic and the therapeutic benefit of IPL, we schedule that and then we evaluate from there on, what's going to need to be the frequency, depending on what other treatments that we're doing that are adjunctive.
Walt, what do you think about this topic?
Well, I've been excited about this topic because, working with Liz before, we've been trying to bring in IPL, and we brought it in right when I was leaving and relocated to be closer to home. But it's been a great addition to the treatment armamentum. And so just as, so Doug's been teaching me quite a bit in regards to utilizing the IPL, where it fits in with the thermal pulsation. But these treatments, they do complement each other. Biggest thing to remember is, this is a chronic condition. And so having that patient back, whether it's 4 to 6 or 5 to 7 months, reassessing, retreating, that's only going to benefit our patients.
Liz, what say you?
Yeah, I think it's, I don't know how much more I can add. Suffice it to say that we've got 2 people who are definitely, they just explained it so beautifully. It really depends on what we find on the lid examination, plus what we're seeing structurally on meibography. And then depending on what they look like in follow-up. So let's say that the cadence is that we see them between 3 to 6 months, depending on the severity of their disease level. And they have some more erythema and telangiectasis, which is so common in those who are at least 1/3 Irish or more. So in those patients, then I would, repeat more IPL in order to try to attack those feeder vessels, because those feeder vessels that are going into the lids, as we know, can, certainly dilate and drop more inflammation. So I think it does depend on how they look and how they respond to initial therapy to determine what kind of cadence and schedule. Before, when we were all kind of picking up on how to do this, we were thinking maybe once a year, maybe, and with micro blood flow exfoliation every 6 months. But now we're recognizing that, it depends on the level of disease, the type of source of etiology, and the severity of structural damage that exists.
Final question here is from Irene. Irene asks, what thermal pulsation devices are you using in your practices? Liz, we'll start with you.
We have the gamut. I will say, if they've got full meibomian gland architecture, my go-to is going to be LipiFlow, because the activator is automated and it just makes it very, very easy. If they have gland dropout, then I prefer iLux, so I can kind of, customize where I'm going to spend a little bit more time, because if they're missing 1/3 of their glands in a certain area, then going after that and continuing trying to melt glands that don't exist doesn't make as much sense. And I don't have as much experience with the tear care product, but I love those manipulator forceps to use anytime. That device is fantastic at manually kind of expressing the meibom after any therapy. So that is a huge plus. And thank you, Sight Sciences, for that.
So
Yeah,
all
what are-
three of those technologies in Virginia. Walt and Doug, you're in the same practice. What are you specifically using for your thermal treatments in Nevada?
Doug? Well, I'm not Doug, but I'm happy to answer. So we have all the different treatments as well. And that's what's been pretty exciting is learning about all the various innovations. We do have the LipiFlow. We do have the iLux. Excited to get our hands on the iLux squared, which should be out here in the near future. The Site Sciences with the tear care, as Liz just mentioned. We have a buddy, that Tom Chester out of Cleveland, and he says, whenever I do tear care, I can see, because of the manual expression, he could see the meibum coming out. He could see the inspissated glands. And so that's one of the huge benefits of that. So utilizing all of them within the practice, as Liz mentioned, if they have diffuse or if they have majority of their glands, thermal pulsation, that's where that comes in with LipiFlow. If we need to personalize it, that's where something like the tear care or the iLux would come in for us.
So that, again, fantastic session here to start at Eyes on Dry Eye. Doug, Walt, Liz, that was so much fun. Over 1,000 people. We're off to a flying start. We're going to go ahead and take a short break here. I do have our very first bonus raffle code, though. I just got this. Our raffle code, first one of the session, is hyperemia. HYPEREMIA. Hyperemia is your bonus raffle code. Go check out the exhibit hall. Make sure you go to the conference bag. Donate $1 on our behalf, on your behalf, to the Sjogren's Foundation. Go check out the exhibit hall. All sorts of cool stuff going on. We'll be back here in the implementation track in about 10 or 15 minutes with the MGD myth, brought to you by Tear Care.